Pena, the founding director and vice president of global health at Northwell. For Eric, thanks so much for joining us today.
Thanks for having me.
As background, Northwell Health is a health system based in Long Island, New York, specifically Melville, right in the middle, with 6,600 beds and 14,500 providers across 24 hospitals and other care facilities with 100,000 employees. So, Eric, we're excited to be talking today about Guyana, Ukraine, and why a health system in the United States should be caring about international medicine. So, please tell us a little bit about what you're doing in those countries and what your global health program is up to these days.
Yeah, thank you. It's great to be here, like I said, and you know, um, it's been a privilege at Northwell. I've been the kind of founding director and now vice president of the Center for Global Health at Northwell since 2019 when we founded it, and it really was answering the question, can a health system do something a little bit more than the traditional medical mission model where it's basically where we passively allow physicians to go out and do this work internationally that they like to do and that they enjoy doing. Is there a way that we could organize it, put some structure around it, and have that energy get captured and be a better value to a partner internationally? And actually serve some value to the health system. And that's really kind of what the Center for Global Health's forming thesis was,
Hmm.
can we take all of this goodwill, all of this desire to give back and travel abroad and teach and really organize it around specific projects? And we as you said, we have two big projects that we work on. Our flagship project in Guyana, which is the only English speaking country in South America, and then Ukraine is our second site, which really started at the request of the CEO emeritus, the prior CEO of Northwell, Michael Dowling, after the full-scale invasion in 2022 of Ukraine.
Excellent. So let's start with Guyana. I understand that they're undergoing a digital transformation from paper to electronic health records. So many of our more seasoned and tenured listeners may remember this happening in the United States a few decades ago. What's the program looking like?
Yeah, so right now we've got a program that has, we're engaged in over 17 departments and service lines in Guyana. So there's really a lot of activity. It's one of what we call a core site, which really means that the health system has engaged in a 5-year partnership with the government and the largest public hospital there in essentially doing in-kind healthcare kind of advocacy and health system strengthening work. Based on what they need. And so everything from psychiatry to pediatric urology, we've basically brought to bear in Guyana. One of the big projects that they're doing, as you mentioned, is they've kind of contracted their first electronic medical record. And as they're building new hospitals and starting to bring new facilities online, they're also looking at digitizing kind of their existing health records and health infrastructure. It's a pretty daunting task. I think right now at most hospitals in Guyana, the amount of medical record storage is probably a fire hazard in most of the hospitals. Like even we say it in jest, but the CEO of GPHC, which is the large public hospital, the quaternary care hospital in Georgetown, which is the capital, said that like they were actually in the file room, they ran out of space to put their medical records because they had such a volume of paper records. And when you think about modern care delivery and how complicated modern care delivery is, to try and document that effectively on paper is essentially impossible. And so they realized very quickly that they were going to have kind of enormous challenge, not only in switching to an electronic medical record that's hopefully starting from all the mistakes of the past, 30 years of medical records, but not only that, they had this enormous wealth of paper data that they were going to have to, in some way, kind of make workable and usable. So we've been working with them, and other New York health systems are engaged on that. Our specific cutout right now is in the pre-hospital space, and we're looking at taking their ambulance service, which isn't a national ambulance service, and creating a national ambulance authority that will respond to emergencies countrywide, dispatch ambulances, provide a record of patient care, and then have that record of patient care seamlessly integrate into the larger hospital systems EMR. And so that's kind of the piece of this that we've taken on and are spending a lot of time thinking about right now. And it's even that I think has enormous challenges and things that you wouldn't think of coming at this from the United States.
So, Eric, there's just a million topics you covered. Talking about that, let's talk about the specifics of what Northwell is providing. First of
Yeah.
all, I'm thinking, is it mentorship? Is it actual physicians and nurses, provider caregivers giving care? Is it consulting? What exactly,
Yeah.
specifically, are the resources being allocated from Northwell to Guyana?
So it's a little bit of all of the above that you just mentioned, with an emphasis on we're trying very hard not to be the ones providing medical care. So
Hmm.
with very limited exception, are our docs and nurses functioning as docs and nurses
Hmm.
in Guyana? It's really we do some campaign-based work where we do some surgical campaigns and help them clear backlogs, but that's the exception and not the rule. I would say the rule of it is really in-kind consulting, mentorship, leadership development, everything from launching a new modality of psychiatric care, so electroconvulsive therapy, which has been used in the States for years and years for refractory depression and schizophrenia. We launched that service with the public hospital in Guyana. So helped them acquire the machines, trained all the nurses, the anesthesia docs, the psychiatrists, so that they were able to deliver this modality of care, and then helped them launch that service, and then provided kind of not just tech support, but in-kind support kind of to the program moving forward. And so that's one example, but it's really kind of full thickness partnership, I think is the best way to describe it. Um, our docs get a lot out of this too. Like our doctors come back from these projects and they say, I spent a week there in country. They've now normally the week visit from an attending physician is buttressed by weeks and weeks of virtual meetings before and after. But then,
Hmm.
we encourage a lot of our providers to do a site visit, to see the country, to see the providers, to see the clinical environment for themselves. And they come back and they say, this has been one of the most valuable parts of my career, in terms of the exposure, the ability to form kind of intercultural professional bonds
Hmm.
with people in the same discipline that are facing very different challenges.
Hmm.
Um, and there's a kind of what's gets described as a kind of a purity of the medicine. Um,
Hmm.
because most countries, it's not hard to go to a country that has less focus on medical, legal, and billing than when you leave the United States. Basically, any
Hmm.
country you go to in the world, you're probably doing a little bit better than you
Yeah.
would be doing here.
So, there's great expense associated with all of this. Is all of this funded by Northwell Health's largesse, or is there funding from the World Bank or IMF? And this is going back to the original premise of this conversation, which is, for any of our listeners this episode, why would they be interested in initiating some sort of uh, program at their institution? So funding and
Yeah,
ROI.
it's a great question, and it's a question I get asked often, as you can imagine. It started out 100% seeded from the Northwell budget. This was kind of an idea, a twinkle in an eye, and so it's tough to get funders, especially when you're 30 years behind kind of the other major academic medical centers in terms of global health development, to say, "Hey, fund this idea that we have."
Hmm.
So it was seeded through Northwell's budget, and Northwell still has significant stake in the game.
Hmm.
Um, but our programmatic expense, so the expense of travel, um, the expense of kind of program delivery, has been offset about 70 cents on the dollar, and
Hmm.
that's offset by either government grants, so direct from the government of Guyana or the government of Ukraine, individual donors. So we have an individual donor pool that is interested in this kind of work and seeing this kind of work, and then the other part is still, there's about 30 cents on the dollar that's Northwell budget funded, and that's kind of our stake in saying that this is important and our part of the partnership.
So, since this is Healthy Data Podcast, I'd like to ask a few data centric questions.
Sure.
Data centers, connectivity, broadband infrastructure, latency. These are questions I'm sure many listeners are considering. Obviously, clouds is cloud an option out there? Commercial cloud, Is it only on-prem? What about data security, security of a data center? Is there a data center there?
Yeah.
How, please.
Yeah, no, it's great. Those are all great questions, and it's funny because this week I'm grappling with some very similar questions with with computer assisted dispatch for 911 and EMS. Their cloud is a feasible option in Guyana. Broadband internet is pretty ubiquitous. Certainly in the capital and in the coastline cities, direct broadband or 5G or LTE style kind of mobile service is pretty ubiquitous. Um, in the hinterland of Guyana, which 95% of the Guyanese population lives on the Atlantic coast, on the north coast. The other 5% lives in a very large part of area that's got very low population density,
Hmm.
population centers of 2,000 or less. What the ministry has done, the Ministry of Health has done in those cases is they set up health centers and health outposts, and each one of them is set up with a low Earth orbit satellite connection. And it's actually all Starlink at this point, because Starlink is the most reliable of the low Earth orbit, at least in South America. So
Hmm.
we're able to not only digitize the health post, but it's got enough broadband that we actually give the community members digital access as well. So they are able to get online for a certain amount of time per day where they can log in and check email and access the digital services the government is offering. But it does have its limitations, and we've been thinking about things like everything from ambulance connectivity and EPCR and remote computer assisted dispatch all the way through to like remote robotic surgery, which the
Hmm.
president of the country has challenged us to do in Guyana. Things like latency are really important, right? And
Hmm.
now in low Earth orbit satellites, you can kind of plan for the latency, like it's low latency, and then there's some interruptions, like scheduled interruptions in the connectivity that we're thinking about. But it's certainly a challenge. The data privacy laws in Guyana, again, that's something that we're working through right now with the National Data Management Authority, because there is a law that says that most health data needs to stay in Guyana on premises somewhere. They
Hmm.
don't really have the data center needed to run. The cloud would be a much better option for them in terms of computer assisted dispatch software.
Hmm.
And we're trying to figure out kind of how that's going to work. But these are, really relevant questions that the government is struggling with right now, which is how do we protect our citizens' data? How do we not let regulation get in the way of digitization of our health system, which is badly needed, and balance kind of those two competing forces? Add the third part, which is because Guyana is so small, the population of the country is under 1 million people,
Hmm.
and it's a new market for most of these companies. Even getting companies to pay attention and sell their cloud service to a place like Guyana, where they view, a new regulatory risk as being a legal risk, is it worth it given the low numbers of patient encounters? It's been challenging math for us, and it's one of the things that I think kind of countries that still have developing healthcare systems are having to contend with. I remember having a conversation with the Prime Minister of Barbados, and she told me that they called Epic to bring
Hmm.
Epic to Barbados, and they didn't even return their phone call because it's too small of a market. And
Hmm.
so, there are challenges that I think these countries face that we don't even think about sitting in New York, with the world at our fingertips.
Well, all right. Well, this is an interesting conversation, and that's why we're having an Unhealthy Data podcast. Before we go to Ukraine, and I want to get to that topic,